Good evening, everyone. I must thank the organizers for giving me the opportunity of sharing my thoughts on current status of non-culprit revascularization in patients of STEMI. As you all know, revascularization is the backbone in the treatment of patients with ST elevation myocardial infarction, and primary PCI has definitely improved the outcomes. However, when we do the primary PCI, we've noticed that about 50% of these patients also have some non-culprit lesions, and these are associated with worse outcomes. As you can see on the slide, those who had the non-infarct related artery or disease, they had worse outcomes, and this is particularly true because they undergo incomplete revascularization, and this is commonly seen in elderly and diabetics, patients with heart failure, and those who have prior myocardial infarction. So the slide here shows you a very common scenario, two cases, one with anterior, one with inferior wall MI, and both of them have got non-culprit lesion, a significant LAD and RCA disease. So what should one do? So this is the question which we'll answer over the next 10 to 15 minutes. There are some risks and benefits of revascularization. Let's look at the benefits. The benefits primarily stem from the fact that you decrease the infarct size, you reduce recurrent MI by causing plaque stabilization. You also reduce the length of stay and reduce the recurrent ischemia, which all lead to improvement in the prognosis. So what are the risks? The risks are it's an unstable situation, and you might end up increasing the infarct size by causing more distal embolization. You're going to use more contrast, so it might translate into contrast-induced nephropathy. You're going to use a lot of anticoagulants, the bleeding risk increases, and you definitely add on to the cost, which is very important in the Indian setting. The other major problem is that the assessment of the lesion can be slightly difficult because in the acute MI situation, you have coronary spasm, and you will not be in a position to assess the lesion properly. And the final question which a lot of people ask is that, why do this lesion? It is not for this lesion that the patient has come onto the table. So if we have to revascularize, how do we decide? What are the parameters which we use? Age-old coronary angiogram, we know that it's got its own limitation, but this is the one which is most commonly used. You can use coronary physiology, IFR, FFR for the assessment of lesion, and imaging. So these are the three tools which we use for deciding whether we need to intervene in the non-culprit lesion or not. Let's look at the angiographic data. This is the slide which has been taken from the PRAMI trial. There, when they revascularized lesions with 90 to 95% stenosis, they detected 20% of the event causing lesions only. However, when the threshold was changed, it was when they included 75 to 99% of stenosis, they detected almost 81% of event producing. So angiography has got its own limitations, and as I told you, there is a lot of catecholamine surge during STEMI, and the lesions can appear to be more severe than they actually are. Physiology has emerged as an alternative, and FFR, IFR, they have become a very valuable tool, and we have enough clinical data to support their usage in different clinical scenarios. Is FFR reliable? The FFR certainly is reliable, as is shown on this slide in this elegant trial. The FFR done for the non-culprit lesion in the acute stage as well as during the follow-up did not show any variation. One can reliably use a physiological tool for assessing the severity of coronary lesion. Imaging has been around, and you can pick up a lot of thin cap fibroatheromas or the unstable plaques. These are the plaques which are associated with adverse outcomes. But do we have enough data to support this? Recently in TCT Connect, we had the Prosper Absorb trial data being presented. This was a trial which used IVUS along with near-infrared spectroscopy to assess the unstable plaques. They looked at the plaque volume as well as the lipid core. And what they found in their study is that at the end of 2 years of follow-up, those plaques which had more than 70% of those lesions which had more than 70% of plaque burden, they had more number of events, both at the level of the patient as well as at the lesion. And this slide shows the near-infrared scopy data. The lipid core, the larger the lipid core, more were the events. So a lipid-enriched plaque certainly translates into more events when followed up over a period of time. Well, what is there for us from the clinical trials? This is how we select. We can use coronary angiogram imaging or patient symptoms. But what are the lessons which you've got from the clinical trial data so far? Well, as I told you, we have three options in patients in multivessel PCI. Either we do the revascularization immediately, or we do it in a staged manner, or we have the conservative arm where we put the patient on medical therapy, which is not the one which is followed over in majority of the patients. So if you, and you can stratify them based on angiogram. This slide shows the angiographic stratification, which was done in the PRAMI and culprit trial. These were the patients with multivessel PCI, multivessel disease at the time of initial presentation for STEMI, and they were stratified based on the angiogram. So in the PRAMI, where there were about 450 odd patients, they non-culprit lesions were addressed. So about half of the patients underwent a preventive PCI, and these were noted to have lesser number of events. In the culprit, there were about 300 odd patients who underwent, of which half of them complete revascularization. These were both very small trials, and they were not powered to detect the death and MI. So, but all the same, they had a tremendous impact. And as you can see in this, the ACC/AHA guidelines for 2013 put in red the PCI for the non-culprit lesion. However, post culprit and PRAMI, these guidelines were revised, and they were changed to 2B. So now the revascularization of the non-culprit lesion had become class 2B in the revision or the focused update, which came in 2015. Well, if you stratify these lesions physiologically, that means using IFR or FFR, we had two elegant trials, which were the Dynami 3 Prime Multi and the Compare Acute. In these, both the trials, the lesions were stratified on the basis of the physiological assessment. FFR was used in both these trials, and complete revascularization was done during index PCI in Compare Acute and during index hospitalization in Dynami Prime Multi trial. And it was noticed that both these trials, complete revascularization translated into lesser number of events, and they produced a lot of beneficial effects. So to summarize what I've till now is that the initial registry data suggested that the treatment of primary PCI, the non-culprit lesion of the primary PCI, is harmful, and that is how in 2013 guidelines said that please don't touch these lesions. However, there were small and medium trials as well as meta-analysis which suggested the benefit. But this benefit was essentially based on reducing the number of revascularization and without addressing the composite hard endpoints of death and myocardial infarction. So there was a need for a larger trial which could assess, and a step in this direction was the recently published complete trial, which randomized STEMI patients into complete revascularization or culprit vessel revascularization. This trial had about 4,000 plus patients, and the complete revascularization was done either in a staged manner, in that it was done within a median period of 23 days, or was done during the index events. These patients were followed up over a period of 3 years for the composite primary endpoints, and the trial data was very, very encouraging. It showed that the complete revascularization was achieved in 90% of non-culprit lesions with a residual syntax score of 0. It led to reduction in the cardiovascular death and MI by 26%. And if you add to this the ischemia directed revascularization, the benefit increased to 49%. So the message was very clear that when you revascularize the non-culprit lesion in patients with STEMI, either during the index hospitalization of the median duration of 1 day or in a staged manner, you achieve a lot of benefit, and you do not have any significant difference in the bleeding, stent thrombosis or AK rates in these patients. Well, there's another study which came out in this year, which was published in the JAC. This was the co-op registry data, which looked at ACS patients, and they had a substantial chunk of STEMI patients in that. And this also showed that complete revascularization is the way forward, because it reduces the all-cause death, new MI, and target vessel revascularization. It also identified the subsets which derive benefit, the improved outcomes are noticed in patients who are younger than 75. Patients who are a little older have more comorbidities and hence have bad outcomes. Male patients benefited more because it was seen that the female patients have very few non-culprit lesion and they are less likely to rupture. Higher disease burden was associated with worse outcomes, and the benefits are noted in those irrespective of their diabetic status. So almost all the subsets of ACS, which includes unstable angina, non-STEMI, and STEMI, benefit from complete revascularization. There's another important subset which we commonly get to see when the patient presents to us with STEMI. These are the patients in cardiogenic shock, and this could be seen in about 30 to 40% of patients. The earlier guidelines recommended that we should revascularize the non-infarct non-culprit lesions in these patients, but there has been a revision in this. This revision came after the culprit shock trial, in which it was noticed that complete revascularization was associated with worse outcomes. It is recommended that one should do a stage PCI for the non-culprit lesions in patients with cardiogenic shock, and this was shown to be leading to lesser number of deaths and renal replacement therapies at 30 days and 1 year. However, this does entail the risk of higher incidence of heart failures and repeat revascularizations in these patients, but one should not attempt to do a complete revascularization or address the non-culprit lesion in patients who present with cardiogenic shock. The STEMI guidelines from the European Society of Cardiology have been accordingly modified, and in 2018 STEMI guidelines have made NCL revascularization class 3. To summarize, what I have mentioned is that it is prudent to revascularize the non-culprit lesions, but there are certain factors which have to be kept in mind. Patient stability is most important. As I told you, patients with cardiogenic shock don't do very well. You need to accurately localize the lesion and identify the culprit of the non-culprit vessel. This is particularly important when you don't see a thrombus-laden lesion, and more importantly in patients who have got multivessel disease. You can have these patients with complex morphologies with almost 20% coming with calcification, 15% coming with CTOs. So you really need to assess the significance and address the lesions accordingly. Patients with anterior wall MI draw more benefit out of non-culprit vessel revascularization. The success of the given procedure, depending on its complexity, has to be kept in mind. And as I told you, one should not go ahead and attempt chronic total occlusion at this stage, because it is best left to be done in a staged manner. Above all, there are certain risks of intervention. You can cause contrast-induced nephropathy, more so in the elderly patient, diabetics, and in patients who have come in cardiogenic shock. So one has to, take a very balanced call, and one should thereafter attempt to revascularize these patients as soon as possible, and preferably within the first 45 days. So what will be my approach to patients with STEMI? Well, if I have an acute STEMI with multivessel disease, I would, if there is no multivessel disease, I will just do the primary culprit vessel lesion and the matter is over. If there is multivessel disease, then I would address the significant non-culprit lesion if the patient has ongoing ischemia or the lesion shows thrombus, ulceration, or plaque rupture. What the caution here is that I will withhold the PCI if there is chances of patient developing contrast-induced nephropathy, he has intolerance to DAPT, or there is TIMI2 flow in the culprit vessel. Even those patients who have very high syntax scores will also be staged. In a stable patient, you can always hold off and do the non-culprit lesion within the first 45 days. Whereas some of these patients might need a referral for CABG. These are especially those patients who have multiple CTOs or have very high syntax scores. So one should keep all the options open. To conclude, I would say that immediate and staged complete revascularization within 45 days of the non-culprit lesion in patients with STEMI is associated with good clinical outcomes. However, this has to be attempted judiciously. It should not be that you know that addressing the non-culprit lesion is going to translate into benefits. You go ahead and do all of them all at the same stage and subject the patient to adverse outcomes. We need further long-term follow-up to define the outcomes better. Till then, I very strongly advocate that the non-culprit lesions post-assessment, either angiographically or using the physiological tools, needs to be addressed within 45 days period of the index event. Thank you.